Okay. Welcome back, everyone. I hope you've all had a good lunch and a chance to discuss with your colleagues from across the world, the many patient organizations that are here in this room. My name is Liam Galvin. I'm based in Ireland. I'm a volunteer with the Irish Lung Fibrosis Association and one of the co-founders and the CEO of the European Pulmonary Fibrosis Federation. It's a pleasure for me to co-chair this afternoon's session. In this session, our focus is on mental health and lung disease. For most of us in this room, we know that anxiety and depression is a common comorbidity of whatever disease group we are from. It affects not just patients, but their families, their carers, and even their medical and clinical staff who also see the impact on disease and have to live with the fact that they're treating very serious diseases. During COVID, the whole world was highlighted that a respiratory disease has a mental health issue impact on not only patients, but also the fear of getting a disease, a respiratory disease. In my case, a genetic respiratory disease means that patients are wondering whether they will be diagnosed. So all this adds to the burden of mental health in respiratory diseases. So I think it's a very interesting topic for me personally, and I hope everyone in the room and online will enjoy it too. It is now my pleasure to introduce my co-chair for this afternoon, Michaela.
Hi everyone, my name is Michaela Odemyr. I'm the chair in the ELF Patient Advisory Committee, and I'm also the president in the Swedish Asthma and Allergy Association. I warmly welcome you to this afternoon session, and often seeing this in the morning, the energy, the commitment, and also the engagement, I think it's fantastic. I am pleased to introduce our three speakers on the topic of mental health and lung disease. So our keynote speaker is Professor Andreas von Leupold, a professor of health psychology at the University of Leuven in Belgium. Andreas' research focuses on the interaction between psychology and the respiratory system, and he is particularly interested in how people experience breathlessness and pain. As you can see, he's not sitting next to us due to the cancellation of a flight, but thanks that we have a hybrid, he will be online. We will then hear from two patient organization speakers. Dr. Natalia Moeva is a patient with pulmonary hypertension from Bulgaria who received a lung transplant in 2016. Natalia is the founding member and president of the Bulgarian Society of Patients with Pulmonary Hypertension, and she is also involved in the European advocacy through BH Europe, and as a patient representative in the European Reference Network for Rare Lung Diseases, ERN Lung. Then we have Professor Francesco Pagnini. He's a professor of clinical psychology at the Università Cattolica del Sacro Cuore in Milan. Sorry for my Italian. Francesco conducts research on the Bondi connection and works with the Italian Bronchiectasis Patient Association on activities to support mental health. There will be a question and answer session following the presentation. Now I hand over to Professor von Leupold.
Okay. Hello?
Hello, welcome back.
Okay, so you can hear me?
We can hear you.
Okay, thank you very much. So, dear ladies and gentlemen, dear very, very big sorry that I cannot be there with you and cannot, join you in person because of this last-minute flight cancellation last night. And that did also with my mental health lead to a very acute drop. So I was very frustrated, very sad to not being able to join you live. But lucky enough, we have this hybrid option so that I can at least online try to share a few thoughts here about mental health and respiratory disease. I will specifically talk today about psychological burden in COPD, about the prevalence and impact of it, some potential mechanism of psychological burden in COPD, and maybe even more important about the detection, potential treatment of it, and the future direction in the clinic as well as in research. I selected COPD as a prime example here for mental health issues and respiratory diseases because a lot of the literature comes from this particular disease. And also my own expertise is a bit more focused on COPD. However, a lot of the facts that I want to talk about, they also hold for many, many other respiratory diseases, as we have already heard in the introduction by Liam a few minutes ago. My presentation is mainly based on these two previous publications and reviews that come from a specific scientific working group, 9.4, from the European Respiratory Society, psychologists and behavioral scientists. So this group works a lot around these topics, mental health and respiratory diseases. And if you're interested in that topic, we are warmly welcoming you to become a member of our group. Support us, please. And as an ELF member, you can, for just a few bucks, become a member and be active also in this group. So another interesting literature resource is this book here, which also for those interested is a very nice source of information. Okay, let's start with the very first question here of my talk. How prevalent is psychological burden in COPD? And if we start to look at the literature across different studies, we see it is very difficult to obtain very precise numbers. How prevalent is this? So if one looks here across different studies in the prevalence rates of anxiety and depression, we see some studies find only 2% here, whereas other studies, they find about 80% prevalence, so in about every patient that was included. So that's quite a range. This is related, of course, to differences in the measurement instruments that were used, the differences between patient, the settings, and so on. However, if we compare that or group that a little bit, we see that in more stable forms of COPD, depression rates are 10 to 40%, anxiety 10 to 20%. But the more severe the disease gets, we see much higher rates, up to 70% of depression and anxiety rates here in severe COPD, for example. And this is, of course, very high prevalence rates and much higher in COPD than in controlled samples with or without chronic diseases. Important to note is actually to also keep a broader view. So this is what we highlighted in the recent review as well, so that we do not only look at very severe forms of psychological and mental distress, meeting diagnostic criteria here on top on the pyramid, but that we also look at more subclinical levels and maybe even more normal psychological reactions to a disease like COPD. For example, that you are frustrated because due to an exacerbation, you cannot participate in a family party, something like that. So also a broader view is important here. An important note is that this mental health burden, psychological burden, is in very many cases not diagnosed. So not even every second patient that has both COPD and comorbid depression and anxiety is detected as such, and what you don't see is difficult to treat, right? So not even 1 out of 3 patients with comorbid depression and anxiety receives any form of treatment for these comorbidities. And finally, we also heard that from Liam in the beginning, also caregivers and family members, they are at an increased risk for anxiety and depression, and almost no one really cares about those people. Okay, so we have now heard psychological burden is indeed a problem in COPD, but what are now the effects that it has on the life and on the treatment in these patients? Let me give you now a couple of very different examples of different fields that are affected. First one is the so-called medication adherence. So that is the way that patients take the medications in the way that the doctor has prescribed it or recommended it. And we see here on the left-hand side, this is, by the way, an Irish example here of note, maybe for Liam as well. Here they ask patients how well and how good they to take their medication. We see that quite some patients here in blue, they report that they have difficulties to take their medicine, so sometimes stopping medications when they feel better, sometimes even if they feel worse. And one of the predictors for this, let's say, reduced medication adherency is high levels of depression. So people with COPD and comorbid depression, they are less adherent to their medication use. Then maybe logical, if one doesn't take the medications as one maybe should, this may lead to a worsening of the disease requiring hospitalization or emergency treatment, and this is what we call an exacerbation. And in this large study here from the US, we see in the white bars that those COPD patients that have comorbid symptoms of depression, partly anxiety, they have much higher rates of ending in the emergency room here or having a hospitalization here. Unfortunately, quite a number of patients, if they were released from the hospital, from the initial hospital visit, they need again a treatment within the following month. That's what we call a 30-day hospital readmission. Because, the disease again, within a couple of days or weeks, became worse again. And in this large US study here, we see that those people that are readmitted to the hospital within 1 month, that they often have a much higher rate here of comorbid depression, anxiety, psychosis, and some addiction problematics here. Another example concerns pulmonary rehabilitation, one of the most effective treatment forms that we have for COPD and many other respiratory diseases. Also here we see that those patients that have higher levels of anxiety and depression as a comorbidity, that they have worse outcomes here of this rehabilitation program. We see that before the PR program, as well as after this 3-week outpatient PR program. And reduced outcomes are in functional capacity, so people can walk less fast, less meters than others. They report more dyspnea, and they also have a reduced quality of life here. Quality of life is another keyword here in this study, where we see that anxiety and depression is not only associated with reduced health-related quality of life, but that other comorbidities in these patients, they have much less impact on the health-related quality of life. So in other words, if you have diabetes or cardiac comorbid diseases, that is not affecting the patients as much as these comorbid mental health comorbidities. And you may imagine that all these increased treatment forms, then that this also costs a lot of money. And we see here in this large study from Dalal and colleagues that the healthcare costs for patients that have both COPD and comorbid depression are much higher, with $28,000 here, compared to those patients that only have COPD and a better mental health status, only $22,000 treatment costs a year. And maybe one of the most sad outcomes that one can look at is mortality rates. And we see in this study is that those patients that have a comorbid depression, at least the male patients, they have much higher mortality rates over a 1-year period compared to those patients that don't have this comorbid depression. Yeah, it's almost double, or it's more than double the amount here of people. And that's, of course, a very sad outcome. Maybe important to notice that so far we talked about psychological burden more in a general form. So anxiety, depression, negative mood is something which is not specific for a respiratory disease. So about every person can have that given the right circumstances. However, there is a more current approach, a relatively new approach, and that is to look at symptom or more disease-specific burden. And keywords here are breathlessness, catastrophizing thoughts, or very negative beliefs about breathlessness, fear of physical activity, fear of breathlessness, the avoidance of activities, and so on. And this is maybe a good approach here because it may have specific relevance for the patient with a respiratory disease and may also yield more specific targets for treatments. And I will give you two quick examples here from our own work. We measured here in an inpatient pulmonary rehab center in Germany the level of fear of physical activity with a specific questionnaire. We see that those patients that have a very high fear of physical activity, which often leads to breathlessness, they show reduced functional capacity in the 6-minute walking test, reduced quality of life, and also more dyspnea, more breathlessness during activities. And this even holds if one controls for these more general levels of anxiety and a number of other comorbid and other factors, such as age, gender, smoking status. And the same we see if we look at effects after a pulmonary rehab program. Those patients that show higher levels of fear of dyspnea at the beginning of a rehab program, or higher levels of fear of physical activity, on the right-hand side, higher fear of disease progression, they show worse improvements in quality of life over the treatment period and even 6 months afterwards. So as a little summary, as an interim here, depression, anxiety, specific fears, they are related and associated with a whole lot of negative outcomes across a whole variety of fields: physical functioning, social functioning, quality of life, mortality, more symptoms, more costs, and so on. The question is then, maybe for you or also for me and other researchers, so what are potential mechanisms of this high psychological burden and COPD? So why is it that this is so prevalent in these patients? And there are different hypotheses about that, and I must say it's still a very ongoing research field, and a lot of questions are not answered till today. But one hypothesis is that the high burden of the disease may subsequently, over time, lead to increased psychological burden. And I guess that maybe many of you in the audience may know this pathway from own experience, because all the requirements of such a chronic disease, this may lead to frustration, it may lead to anxiety, and to mental health burden. So we have quite some evidence about that from respiratory populations and studies. But interestingly, we also have evidence for the reversed way. So there is data showing that also if people have a high level of psychological burden, bad mental health, that this later on over the years can lead to more symptoms or support the development of COPD. And finally, we have this finding that there may be one common factor, or maybe different common factors, that underlie both psychological burden and the development or the worsening of COPD. And prominent examples here are smoking, or physical inactivity, inflammation, or loneliness, which are all known to contribute to high psychological burden, but also to increase the symptom burden of respiratory symptoms and of COPD. And finally, brain processes, you see it here, and you may wonder, so how might that be linked to mental health and COPD? So I will give you one quick example here, how that is researched. We did this a couple of years ago in Hamburg, where we were putting patients with COPD and age-matched healthy controls into a brain scanner. And we were making their breathing for a couple of seconds a bit more difficult by breathing through the breathing system here. And the people were informed in a couple of seconds, your breathing will be made more difficult. And what we see here is that during the expectation of upcoming dyspnea, of upcoming breathlessness, these patients show much higher brain activations in two regions, in the hippocampus and in the amygdala. And you might think, so yeah, and what does it tell me? Well, both of these brain areas are very prominent for and very important for the processing of human emotions, such as fear and anxiety. So you can interpret that the patients here show more fear-relevant brain activations, and this was associated with a reduction in exercise capacity, higher levels of dyspnea and anxiety in daily life, and also reduced quality of life. So some sort of an interaction in the brain between more emotional processing and reductions in the everyday life and outcomes that are relevant for these patients. Okay, important question is now, well, how can we deal with this psychological burden in COPD? How can we detect and treat it? And there are several important points. One is, of course, to increase the knowledge about psychological burden, about mental health and symptoms in patients, because often they don't know about things like depression or anxiety. And good thing is to maybe use leaflets such as this from the ELF and ERS, which informs patients and maybe also the family members. However, also the caregivers, medical personnel, nurses, doctors, they also should have more knowledge about how psychological symptoms look like and what it is all about. Then it is important, of course, to screen for signs of bad mental health, for psychological symptoms in the clinical life. And one very easy thing to do is that one asks simple questions. So are you currently feeling sad a lot, or do you worry a lot? Another method would be to use more elaborated questionnaires, such as the Hospital Anxiety and Depression Scale, that asks with a couple of statements whether there may be signs of depression and anxiety. Or one uses more elaborate clinical diagnostic interviews, which require a bit more training to do so. And when one then has detected relevant signs of mental health issues, of psychological burden, then of course that should be treated. And we have seen over the years many different forms of treatments and interventions that have been tried out in patients with COPD and also with other respiratory diseases, of course. And these range from telemonitoring, from collaborative care models, mind-body exercises, psychotherapy, and so on. The problem is that for many of these forms, we still have only limited evidence how good they really are. So we have, for example, here in this example table, 3 examples for different evidence levels. We see in green that pulmonary rehabilitation has a lot of evidence that it is also good to reduce anxiety and depression levels in COPD. We see in yellow that psychotherapy, especially cognitive behavioral therapy, is very promising to reduce levels of anxiety and depression in COPD, whereas for other forms, integrated disease management, we have so far still limited evidence, and we need much more randomized controlled studies to show us which are the long-term effects of these treatments, which format is good for which patients, in which doses, and also who pays it. Okay. Having heard about this so far, one could think, well, we have a lot of knowledge about mental health in COPD and respiratory diseases. Aren't we there yet? So couldn't we just stop with our clinical research about this? And the clear answer is, of course, no. So we have a lot of fields where we in the future have to invest much more research and clinical efforts to improve the situation of people with comorbid psychological burden and respiratory symptoms. And I will just briefly mention it. It's on the one hand side, we have to refine our measurement techniques, so questionnaires, for example, and also how to inform patient caregivers what mental health issues could look like. We need also, I just showed that in this table, we need to refine the interventions to treat it. We also need to involve patients and caregivers much more providing more information here, developing further supports. And finally, we also need to involve more mental health specialists in the treatment of respiratory diseases. And that also requires some restructuring, I think, of organizational and financial aspects of our healthcare systems. Okay, let me quickly summarize. What did I want to share with you today? Psychological burden in COPD is very prevalent, but it is very often not detected and treated. It is related to a worse course of disease in many, many different fields and examples that I provided you. It can be linked by different mechanisms. Psychological burden in COPD needs to be detected using different forms, questionnaires, questions, interviews, etc. And in any case, psychological burden in different forms, if you think back to this pyramid from the beginning, it should to be addressed, it should to be treated using different forms of interventions. And of course, this whole field needs much more clinical and research efforts on mechanisms, on treatments, form, and so on. And this holds, and maybe even much more so, for all other respiratory diseases. And with this, I would like to thank you very much for your interest and your attention, and I'm happy to answer some questions later on.
Thank you for that, Professor, for that most interesting presentation. Now I invite Natalia to present.
Good afternoon, everyone. For me, it's a great pleasure to be here, like a patient who has a very long journey living with pulmonary arterial hypertension. For those who don't know what is this disease, this is a rare disease which occurs the small vessels in the lungs, and most of our patients in end stage of their disease, they need a lung transplantation. Thank you. Pulmonary arterial hypertension is a progressive disease that reduces blood flow and increases pressure in the arteries of the lungs. Usually, pulmonary arterial hypertension affects humans who are in active age. For example, 15 to 50 individuals per million. People of all ages and ethnic backgrounds suffer from this disease, although it's more common in the women. And I want to tell you what, like a woman, I was thinking when I received my diagnosis. When I was a small girl, I wanted to become a princess. My life gave me this gift, and when I was 38 years old, I became a real princess because I was not able to do nothing at home because of my breathlessness, dizziness, and my big fear was the stairs. And here in the hall I see some of our patients who are members of European Association of Pulmonary Hypertension. They are really great heroes, and I would like your applause to them. It's very important when you suffer from rare disease, and when we spoke about rare lung disease, the main is early diagnosis, and also as quick as possible to receive the best therapy. I came from post-communist country, And when I was diagnosed, my doctors told my family that I will live just 2 years. You can imagine what shock was for my family and also for myself. But even that, I am very grateful from one of my doctors who found the best solution. He just told me, Natalia, just make inpatient organization. And I did it. Maybe this was the secret of my mental health. And in all my difficult periods, this keeps me alive. And maybe this is the most important that helped me to save my life, to receive the biggest chance to be transplanted, and now to have a normal life. When you suffer from pulmonary arterial hypertension, you have physical limitation, shortness of breath. You are not able to do nothing like any sports, and this occurs very hard to your emotional impact. And many of the patients who are not sure about their treatment, about their future, usually have depression. And maybe this is the problem who will be solved together with our doctors and patient organizations. Because it's very important to learn to live your life with new diagnosis. It is possible. Early diagnosis means less physical limitation and emotional impact. Here you can see the journey of each patient with pulmonary arterial hypertension. It starts unusually because you live with this about 2 years, and then finally you receive the exact diagnosis. During this 2-year period, you have just high blood pressure, you feel dizziness, and sometimes you have syncopes. And when you went to the doctor, usually they told you, it's a high blood pressure, but it's not, because the pulmonary arterial hypertension is like iceberg. And the most difficult is to find quick the correct diagnosis and to receive the correct therapy. In my case, I received treatments from 3 countries, and I said that I'm product of 3 health systems. The first one is my own country, Bulgaria. Then I was treated in Greece because one of the medicines is not allowed for using in my country. And finally, my life was safe in Vienna, Austria. What I understand in my long 13 years journey in the world of PH, the main is to reach out for support. Because when you suffer from rare disease, it's very hard to believe that you can save your life alone. It's not possible. The other thing is to explore your emotions. Just talk to your friends, your family. Share with them your feelings. And also, Don't be afraid to go to the psychologists. They can help you. Also, you must find some hobbies. In my case, I started to write books. But when I received my double lung transplantation, after that I checked what I was wrote during the waiting period. It was a very scary text. That's why I just take decision to write a children book. And this children book exists, and it's a great honor that this children book, which the title is Casper, Teddy Bear with Blue Lips, is translated in Bosnian, in Croatian, exists in English too, but just like online copy. And all the people and the children who has read this book told me that it's an amazing story. Sorry.
Sorry, Natalia, in the interest of time, would you be able to conclude?
It's very important to make self-management and lifestyle adjustments. And the most important is to promoting patient empowerment, to encouraging the patient to actively to participate in their care, and every patient to have a goal and some achievements. As I said, creating a supportive network is very important. The families, the caregivers, building connection with other similar challenges. Also, it's very important to contact with patient organization who always can help to each patient. Thank you for your attention. I chose this magnificent art of Michelangelo because we are here in Italy. I don't want to make a comment of the art of Michelangelo, just I want to point just to see the finger of the God. This is the power who gave to Adam. And I think that together we can share this power and be connected via patient organization. Thank you for your attention.
Thank you for sharing your very personal experiences there, Natalia. And now I invite Francesco to present.
Good afternoon, everybody. And first of all, I'd like to thank HELF and the Italian Association for Bronchiectasis for this opportunity. Now, we've been talking about mental health. And as Andreas pointed out very well, psychological comorbidities are more common in people with a diagnosis of respiratory disease. And that's not just because of the challenges of the condition. The relationship between mental health and physical health is far more complicated. So we know, for example, as Andreas pointed out, that there could be exacerbation related to anxiety or depression. And so even mental health can impact physical health. And the reason why I re-say that is because I want to emphasize that mental health is essentially a part of health, period. Now, in the specific case of people with bronchiectasis, from the few and from the limited information we have in the literature, we know that anxiety and depression are at highest rate compared to many other conditions. And that means that depressive symptoms and anxiety symptoms are an issue that need to be addressed. But on the other hand, that's not always the case. Actually, only a minority of people with bronchiectasis, and by extension, people with respiratory conditions, receive a proper diagnosis of depressive episodes, depressive disorders, anxiety conditions, whatever. Only a few portion of them have received a diagnosis, and even less have received any form of treatment, of adequate treatment. So that just to emphasize the importance of taking care of mental health. It's a huge need. And given that this is a neglected need, what we're doing today is very much important. Because at first, we need to acknowledge the importance of mental health and why it matters. It matters as much as physical health. In the United States, the American Psychological Association keeps on repeating this sort of mantra, mental health is health, which is right. And sometimes we tend to dismiss this by saying, well, if I feel down or feel anxious or guilty, well, it's okay, we'll pass, and I do not really pay too much attention. But no, these feelings may be very important and may need to be addressed somehow. So sometimes guilt, for example, is a feeling that is just there waiting to be elaborated. And I want to talk about an example of an experience we had with the Italian Association of Bronchiectasis. This is very simple in terms of organizing, in terms of actual organization, but extremely powerful. So what we did was this Lady Winterner Circle. It was an online support group with people, composed by people with bronchiectasis within the association, joined online. And the online was convenient because people could join from all around Italy. Every group consisted in 10 to 15 participants. And it was a meeting once a month with different cycles. But long story short, once a month, we met for about 1 hour and a half. And the setting was straightforward. We had some common rules: respect, non-judgment, and acceptance, which are common rules within support groups. And it was moderated by a clinical psychologist, was me. Well, what did we talk about? I mean, the general organization is very straightforward. But what did we talk about? Well, I was impressed by the number of insights and the kind of experience that were shared by the participants and the kind of reactions and the kind of discussion that was promoted by that. So many participants shared their own experiences. And these experiences were mostly related to the journey with a diagnosis and symptoms management and coping with illness. Fine, that's pretty much where we started. But it was not limited to that. So people share their own experiences even aside the symptoms, following a sort of a common idea that we're not defined by the diagnosis. We're not our illness. And of course, within the group, experiences of fear, challenges, especially relational challenges, sense of guilt, uncertainty, lack of control. These were topics that kept recurring during the meetings. But these were not the only things that were shared. There was a lot of hope and friendship and positive emotions shared within the group. A lot of support. Sometimes people shared their practical suggestions. How I was with that ventilator or with other machine, or going to this center that has a bronchiectasis expert whatever. But that was not for the majority. It was mostly an emotional journey. And so these topics, if I look at them with a psychological perspective, these topics express some needs that were there and screamed to be expressed, screamed to find a way. And so, first of all, there was a need for mutual recognition. The point of sharing my own experience with somebody who may have a similar experience is very important. And listening to somebody sharing this experience is also extremely powerful, a very powerful psychological experience. And that leads to the idea that I do not feel alone, because I'm not the only one who went through that. It's extremely, extremely important. And understanding that somebody has faced some challenges in a similar way I did is reassuring. And sharing one's experience is also positive, because I know that my issues may help. Sharing my issues may help someone else. And the fact that we had this space was it is, because we're still doing it. It has been a safe space in which participants could share their own emotions. It's been a great resource. And again, there was a need to say out loud that we're not our illness, and we shall not be defined by that. Now, the qualitative feedback that we collected after the first round, so after just 4 meetings, were impressive. All the feedback were extremely positive, and the overall impression was extremely supportive and positive. And participants referred to this experience by saying that it was a way to address their fears and challenges. And the fact that somebody could understand, could understand the materials that they brought, the ideas, it was something extremely reassuring and incredible. And there was a certain level of surprise by the fact that we could build such an intimate group, even online, so we never really met in person, and in such a short term. But of course, if the needs are so common and the setting is properly done, that's something not so surprising from a psychological perspective. But of course, what for the future? Well, that's a support group. This is not psychotherapy. So the setting is not appropriate for facing deep challenges that one can still deal with. But again, it may be the place, it may be the location in which somebody will find, oh, this is something I may work on. And it could be the first step to search for a more specific support. And long story short, I think this is a very good example of what kind of interventions can be done that's easily implementable and extremely cost-effective in that sense. So I see that my time is about to run out, so I have a gazillion things to say, but maybe for Q&A. And that's it. Thank you.
Thank you, Francesco, and thanks very much to allow time for questions. We're now going to move on to the question and answer session for our afternoon. If you're in Milan, as we did this morning, you just raise your hand and the hostess will come with the microphone. And for online participants, which I hope there's many, if you can just please post your questions into the question and answer box and we will see them. We'll start with a question on table over there.
Hello, thank you very much for your presentation, very emotional, thank you so much. I have a question for Professor von Leupold, and I don't know if he's there still or not, or he left us.
Are you there, Professor? No. I'm afraid it looks like he's offline.
It was a clinical question I wanted to ask him. I'm the spokesperson of the Spanish COPD Association, APEPOC, and we have about 45% of prevalence having people or patients with affective disorders. And I wanted to ask him if, and we noticed, or we experienced that most of our patients are female. So I wanted to ask him if there is a clinical explanation for this, because COPD symptoms are different in men than in women. But anyway, another time.
Well, we can certainly make it and forward it on to the professor.
He's there, great.
I'm here.
Hi, Professor von Leupold. I don't know if you heard my question. I'm the spokesperson of the Spanish COPD Association, APEPOC. About 45% of our patients have affective disorders, especially women. So as the COPD symptoms are different in men than in women, I wonder if it could be possible that, or it could be a clinical explanation why affective disorders affects more women than men.
That is a good question, and it could maybe be that the differences in some of the symptom experiences that women have with COPD, that this may indeed lead to higher prevalence rates of psychological burden, anxiety, and depression. However, this is also a general phenomenon, also in people without a lung disease. You find several psychological disorders with higher prevalences in females, and especially affective symptoms are often more prevalent in women in general. And maybe as a side note, sometimes some people or experts don't know what the real mechanism for that is. Some people say, well, women are often also a bit more open to talk about their psychological problems and issues. So they are more open and feel more at ease to tell somebody, well, I don't feel good, I feel depressed or sad, while the stereotypical male behavior might still be a bit more, at least, that they would not openly speak about it. Does that answer your question?
Take the next. Yeah, I think we have a question back there.
Okay.
Yes, hello, thank you. This is also a question to Professor Leupold. My name is Gundula Kobelmiller from the Austrian Lung Union. Especially what he just said, that women are more often diagnosed with psychological disorders, depression or anxiety. Maybe men are just underdiagnosed. And my question actually is, the general population also does have depression and anxiety, which is about 12 or 5%. So if we talk about emotional burden of COPD, this is, I think we can say, 3 times higher than in the general population. But I think we really have to make a difference to kind of put that in the same bucket, because that way we cannot really tell the difference in COPD patients and in the general population. But maybe this is excluded already, I don't know. This is my question. Hi.
I don't know whether I fully got the question, but you're of course completely right if you say that maybe affective symptoms, anxiety, depression in a healthy population is maybe different than that what patients with a chronic disease such as lung disease experience, right? Because their other additional mechanisms can play a big role. That's for sure. Fully correct, I think.
Okay, we've got another question at the back there.
Sorry. Wait. Thank you. The question about help for these patients. So it's logical when I'm so bad, I have COPD, severe, I have the depression, logical. Today, there are many comorbidity, these patients. So they have treatment rather huge. Add the antidepressive medicaments that are not often very efficacious. What is a real solution? Only physical activity and social activity. The question, what is the solution?
Can you hear me?
Yeah.
Oh. I don't know if I have the solution, but I want to try to give an answer to that. Of course, the topic is really complicated, and simply saying antidepressant or other drugs will do the job. No, it won't work. It won't work just because it's more complicated than this. I mean, it's a different approach to our health. I think we need an increase of psychological support, which is not just psychotherapy. Psychotherapy is one of the options. There are many others. It's important that we pay attention that there are multiple options that can support mental health. Psychotherapy is, in many cases, an optimal solution. It struggles me that right now we have a huge amount of knowledge about the efficacy of psychotherapy against anxiety and depression, especially CBT, cognitive behavioral therapy, but still it hasn't been applied as much as it should. And psychotherapy is just an example because we have an enormous amount of data about it. But we have group support, we have art therapy, we have very different options that could be implemented. The point is that we still miss the link between the actual needs that the patient population has and the kind of clinical solutions that we can provide. That's why it's important to talk about it. So the solution isn't just one solution, there's no catch-it-all idea. But we have several strategies. We need to build an access point, and we need to have the settings in which these solutions can be implemented.
Thank you. And we have also a question here online. Often patients are diagnosed with little to no practical information given to them about what the disease is and what to expect. This often leads to fear, which often leads to anxiety. How can we make sure that patients receive all the information and support they need? Yeah.
This is super important. It's called patient-physician communication. Again, I don't like the word patient, so the communication with the physician. This is very important, and it's one of the issues. A good diagnostic communication is extremely important, and keep having an open communication, an open relation in that sense with the specialists that are involved in care. This is critical, and that is an issue that goes back to the medical training, that goes back into the fact that physicians have, it depends on which part of Europe, but they may have just a little bit of time to deliver, that's how it's called, to deliver the message, which isn't the best way from a psychological perspective of talking about diagnostic communication. And that's one of the issues we have to solve. First, physicians need this sort of training, and they also need time to communicate. They also need time to sit down with the person who receives that message. And that's one of the challenges.
I will have one more question, from the online, and then from you. This is to you, Natalia. How has the transplant impacted your mental health? And then it's you.
Thank you for the question.
I was so lucky because I was transplanted in one of the best centers in the world, in a general hospital in Vienna. They have extremely good team, so I was happy that I have a very good psychologist there who start to work with me after the third day of my new life. So I'm happy that I have this opportunity, and maybe this doctor gave me the power to come back to my work, because before, in my normal life, before my illness, I was a journalist, radio journalist. And the moment, since 2 years, I'm fully working for Bulgarian National Radio. So I didn't have any troubles on my mental health. So this is help from the doctors. They give me the gaps for my new life. Thank you.
Yep. And the last question there.
Thank you very much for allowing me to have a question. So my question is to both Andreas and to the Francesco. They have given a very wonderful talks, but being pediatrician, what I was feeling that that segment is not being assessed. You are talking about all the adults, anxiety, depression, prevalence, and all that. My question is that how, in what age for children you can assess the anxiety and depression? How can we grade? At what age we can see that what is the level of anxiety? Because as a pediatrician, we know that they have anxiety even in the very first year of life. But having a chronic process or chronic disease, having recurrent infections, recurrent problems, what is the level, how we can gauge? Can we gauge that it's a grade 1, 2, 3, how severe it is? At what age we can do it?
Andreas, do you want to answer, or do you want me to go?
You can go, Francesco.
All right.
You're the clinical psychologist.
Okay. I'm not a children expert, so take my answer with this disclosure. But it depends on the age, of course. We can make diagnosis about children anxiety and of course the mood disorders, even though of course things are slightly different compared to adults, of course. But by the time the children may be able to answer questions, so they have some proper speech skills, then they can also answer our questions. And children are very direct. How do you feel? They respond very, very directly. Of course, before they develop these skills, we can observe their behavior. And so there is a way for us, for experts in child psychology, to understand whether they experience some form of anxiety or some form of, let's say, being upset more in general. Maybe when they're very young, we will not be able to say, okay, that's in the anxiety area or in the depression area. That may be too much. But we are able to spot the difference between some children who are experiencing some psychological distress and others who are just experiencing a more, well, a lower level of distress.
Okay.
Andrea, feel free to.
And maybe, Francesco is absolutely right. There is, of course, also instruments, questionnaire instruments, behavioral observation instruments that are specifically validated for young children in order to diagnose and detect their psychological disorders or symptoms. So there is these instruments. There's also specific therapy forms directed at children. So we have instruments for that as well. And pediatricians, should also have some sort of knowledge about that, actually. Yeah.
Okay, thank you everyone for your questions, and to our speakers, Andreas, Natalia and Francesco, thanks very much for sharing your insights. I'm going to bring this session to a close, and we're going to have a short comfort break now for 10 minutes before starting our afternoon sessions and discussion groups at 3:20 sharp. So please return to the room at 3:20 and we'll live stream and start our discussions then. Thank you, everyone.
So, welcome back, everyone. I hope you had enjoyed the chance to hear each other's experience. And this is what we do. Sharing is caring. We are helping each other. That is the patient role from the organization. So, we will look now at the feedback. I start with you, Liam.
Hi everyone, and welcome back. My first light bulb moment comes from one of the online groups. They've said to us, to quote Dr. Pagnini, mental health is health. Psychological support should be seen in the context of holistic health, and it should be seen to include physio, social supports, mindfulness. So really what they're saying, and they've quoted, is that patients are a constellation of conditions. Breathing is life, and not being able to breathe is highly traumatic. So I think what they're saying there is that, like, we have to think outside of the treatments and look towards a more holistic approach to respiratory health.
Yeah, and here peer support lead to both mental health, both the professionals and the patients, and also with the lived experience. We know now that COVID exposed the mental health issues that those with lung conditions faces: isolation, fear, societal stigma. I mean, this is not new, but now due to COVID, it's been exposed. But can you talk, table 2, a bit more about this? Table 2? Yeah.
Hello. I guess this came about because what we discovered through COVID was that patients began to feel they were a burden on their families, because suddenly they were told they couldn't go out, they couldn't go shopping. We were all in the same situation, but people with a lung condition to a far greater extent. And that has continued after COVID, because we now have people who come to our clinic who are still wearing masks, and they feel like they need to make an excuse for wearing those masks because they have a lung condition. And that creates a stigma for when other patients are there in the clinic who maybe don't have a lung condition. There's this making excuses constantly for the situation that they're in. So I suppose that what we're saying is that that situation existed right from day one, but maybe patients didn't express it to their families, how much of a burden they felt and how difficult their lung condition was for them to cope with. And I think during COVID and after COVID, it became more obvious because we could see it. It was much more of an obvious problem for patients coming into clinic, but then also maybe for the patients within their family group. This was the discussion that we had earlier. Yeah.
Thank you so much.
And we're from table 1. They've got more of a call for action to say that there should be resource centres for mental health to educate patients, doctors and caregivers. And that really they feel that patients need to be coaching patients. So that's probably a call that we should, like, in our own patient organisations, look at. Last year, after we had the patient networking day with ELF, we sort of gathered all this feedback and maybe discussed it and we sort of tried to see if there was something that ELF or our member organisations could do about those topics. So I think we'll be doing that again this year about mental health.
Yeah, and I really like this power of patience, stories with people talking. We saw that with Natalia. It touches, it gets real then when you see a real face. and about their vulnerability, their mental health journey. So this is what we need. And I would like also table 7 to talk a bit about this. Yeah? Oh, 10. Oh, it was a 7 here, sorry. Table 10, please.
Yes, we were talking, really thinking about the question about how we can reach more patients experiencing mental health problems, and just how the sharing of really lots and lots of different patient stories and experiences, particularly from groups, perhaps younger people, older people, where there's still a lot of stigma around talking about your mental health. And we really feel that it's the power of being able to relate to people by hearing their stories. And I think the group felt it's something that ELF and ERS could do more of to support. So that's something I'm sure we'll take back.
Thank you. And I'm also thinking now what Francesco said, you're not alone. And I think this is an important message for many people to know they are not alone with this disease.
Yep, and this is another light bulb moment from an online group, Lisa McNeil's group. And it echoes something that Natalia said earlier about the pathway, that acceptance, accepting the new normal, how your life changes is key to strengthening your mental health. So they're emphasizing that patients have to be sort of supported and maybe sort of guided along that path to acceptance. So a good comment there from the online group.
Yeah, and here we have people who have lung diseases, there's stigma, and also feeling guilty that maybe the family can't go on this hiking trip because not everyone can follow. And I think this also causes a lot of mental problems. But I also would like to call on table 4 to talk a bit more about this there.
Thank you. Yes, we also have talked about the fact that lung diseases, especially COPD, causes stigma on patients because there's the idea now that they have the disease because they have smoked or smoked too much, no? And I heard someone say, you don't deserve that we pay for your cure, no? Because you wanted you are the guilty of your disease. And so it's hard, no, for ourselves to also to reply to people who say this to us. And in the table, someone said that this problem is particularly present on women, maybe because they also feel to be the centrum of the family, and so this is one of the 2 most important things that came out from our table.
Thank you. And I mean, if you see a person, if you see me, you don't know. It doesn't say I have asthma somewhere. I look quite healthy, but I do take my medication every day. So when I say I have problems, I go, oh, but you look so fine. What's wrong? Is this really something wrong with you? So I think this is a very important message. So, and again, what Francesco said, you are not the disease. So this is a very important message also, but also to give the disease a face that yes, you can look like anyone else, but you can't do everything.
Yeah, that's very true. And it's just a case like that is in the same in pulmonary fibrosis. Social stigma, because you use oxygen, because it's a relatively unknown disease, that's something that our patients do struggle with. So like they stigmatize for using oxygen because people might say that it's a quality of life, life choice disease. And they're also, because they look quite fit, people can't understand why they can't maybe climb stairs. So respiratory patients really suffer not only from the disease, but social stigma and lack of awareness. So, which ties in nicely with this comment from another online breakout group, which is information, education, and continuing treatment needs to be holistic, accessible, and transferable. And I suppose the transferable part of that is what we're doing here now, learning from each other and bringing it back to the many, many countries that are represented here.
Yeah, I think we're going back to table 4. They have something more to say, please.
Yes, I'd like to add something now that...
Hang on a minute, the microphone.
Oh, Mr. Can you hear me?
No.
Can you hear me?
No.
Can you hear me?
Yeah, yes.
Okay, it's... No, I heard what Liam said about the oxygen, and it's true, no? But it's fault also of what, for example, what we see on television, no? Usually when the actor is going to die, he is shown with oxygen, no? It's automatic, no? Someone will die soon, and he has the oxygen. So maybe the mass media, no, should help us, no, to make understand that it's not, no, a natural cause, no oxygen, and to die.
Yeah, it always helps to raise awareness. If a celebrity, for example, shows that they have a disease, then it makes more people, oh, he has that disease. Okay, I can relate to that. So we have also here, we should look beyond the patients, raise an awareness and a normalization it among patient and physicians, training physicians on mental health and communication. I would like to invite table 9 to talk a bit more about it.
Hi, so I'd like to focus on the last one then, and then I'll ask my colleagues if they want to add something to it. Often the way a physician talks about the disease or informs parents or a patient about the disease is, let's put it, suboptimal and doesn't help when it comes to mental health and feeling well. So that's why, as a last point, we said it's good to educate also physicians, to raise awareness also there about mental health and about how to communicate.
I can only fill in and say this is why we and other patients play a key role in telling the healthcare professional how life is. They help us with the treatment, but we as patient organization, we help them how to live their lives. Oh, yes, please.
And also, we want to add that sometimes it's not only the patient that needs that mental care, because also the caretakers that are around them, the families, need their advice too. So it is important to have psychological assistance for all the family around the patient, because eventually that support group will need that support. Yeah. Sorry for my English.
No, not at all. It's perfect. Thank you.
Yeah, and that ties in nicely, that last comment, with the remarks from table number 5, who said, don't forget the families. But I would like to maybe ask table 5 to explain a bit more about how it's very important that health professionals help newly diagnosed diagnose patients to get in contact with patient associations. Like, why do you feel that's so important? I think it's preaching to the choir here, but if you could just maybe add a few words and about how you suggest that we should all be working together more closely. Table 5.
Yeah, and I mean, now many of the big illnesses, they have organization, but on the rare diseases, then it's crucial to work together because we want the same goal, to increase the information and education about the diseases. I would like also to invite...
Sorry, table 5.
Is time?
Okay. No. They had a comment, but it's fine.
Sorry?
No, go ahead.
Go ahead. I would like to invite table number 6 to fill out, to tell me what you have been writing. It was so interesting. It's always nicer to hear it in your own words.
Thank you. It's Katie here from PCD Support UK. We were talking a little bit about expectation management from our clinical professionals to the patients. So not over-promising or under-promising what the patient could expect once they have their diagnosis or have a treatment, because both of those things can cause quite disastrous ramifications. And you don't want the patient to think that they will be actually quite well when they're not, or worse than they could be, and then catastrophizing as time goes on.
Yeah, thank you.
This is an unnamed group, but basically they've mentioned about the importance of physician being trained to have skills. I don't know which group that was, if someone wanted to add to that remark. Yeah.
It could be from online.
Table 8.
Yeah.
Yes, so we discussed that we thought that the medical professionals should have training to deal with the aspects of mental health that patients are affected by. And we've got a great researcher on our table, so she's been doing some work already in the doctor-patient relationship. So if that relationship is healthy and there's a feeling between the patient and the doctor, then it's easier to manage the difficulties and be more cognizant of the issues that patients are facing in their own care. Likewise, for patients who are proactive, that demonstrates a level of mental healthiness. So encouraging being proactive about your disease is actually incredibly important for them. And where they have issues, they can be detected and dealt with more readily. So the patient management now, as we know, is hybrid care. There's very little connection with the physicians, video calls and so on. So we have to find new ways of building in relevant content and educational support to patients. Now, there's some fear in healthcare professionals about taking on that responsibility because the training wasn't there and that's not their specialization. But empowering them to at least cover some of the basics, which could be supportive, is very important. And one of the great values, of course, across the patient organization communities is sharing experiences, which help people to relieve the burden of those issues that they have in adverse events or in specific moments of their patient journey. So gathering more evidences, we think also is important, and the ERS and the ELF, we believe, could champion position statements, communication and awareness, and strengthen role models also in the male population who sadly often don't share their issues even before they're diagnosed. So those, I think, are the main findings, unless any of my group want to add on. No, thank you.
Yeah, thank you so much. Well, I would like to thank the group facilitators for their support, and thank you all for your participating. Oh, we didn't have 1 minute, so please. Sorry.
Thank you. I really wanted to tell our light bulb idea because I think it's really important. Actually, all of the patient organizations at this table have experience with mental issues or anxiety and depression in their groups. All of them have programs to support the people, which is fantastic, I think. Not only the physical training, also psychologist training, psychotherapists, positive thinking, whatever. And it's actually not surprising that the light bulb idea here is that 50 to 90% of airway disease patients are affected by depression and or anxiety, and there is no therapy management plan, including therapies or programs to confront that. And this is really a big issue that we have to address to support these patients, or us.
Thank you so much. So now we don't have any more light bulbs, so I move on here. Once again, I want to thank the group facilitators, both in the morning and now in the afternoon, for your support and for all your participation and everything you have brought in to make this day so amazing. And I also want to thank Liam, my co-chair. I will bring this plenary discussion to an end, but I will just remind you, do you remember what Carlos, the previous president now, in ERS, what he said? He said that patients are in the heart of this organization, and this is just how I feel now. And also Monica, the incoming president, say how important it is to get your treatment early in life. And I would now like to invite Kjeld Hansen, ELF Chair, to join me on stage.
Happy to. So thank you so much to the two co-chairs. Thank you for championing this session. So we are reaching towards the end of our day, and I would just like to say how happy I am that Patient Organization Day is back. So that not only are we back, but we are also back in a new format. We are here, 100 people signed up for this day. And for the first time, we have a hybrid version, and we have nearly 500 people logging in on the hybrid version from as far away as Ecuador, Vietnam, Senegal, and Barbados. So a huge thank you to everyone, both in the room and online. It's amazing to have Patient Organizational Day back in real life and in hybrid, and I hope this will be the future. So I think this is a great day, and it's a great day because we get to do our patient work. And it's great because we get to do the patient work together. I think there were some excellent examples of how the social connection of patients and how the possibility of sharing experiences not only makes us feel better, but also makes us stronger and make us grow this movement together to make changes, and not only changes for ourselves, but changes for our whole community. And I think we've come a long way doing this, and I do look forward to following the journey moving forward. One person who's going to be with you on that journey moving forward is my successor. It's Dimitris Kontopidis. He is a Greek patient, and he is a patient who also knows the importance of social connection. Dimitris is the ELF awardee of 2021 because of his excellent patient work in Greece, where he alone challenged a magnificent system, and he did challenge it by not letting his peers down. He put his own health at risk in order to serve others. And I think you'll be very well served by having Dimitris here. I want to welcome Dimitris on stage and look forward to hear what you have to say to the people of the organization that you are going to help lead for the coming 3 years. Welcome, Dimitris.
I would like to welcome you all from my part also. Kjeld is a very humble professor. I don't know if you have noticed already that. And through the last 6 months that I was his shadow, I want to describe what I have felt. And I have found a teacher and coach for me beyond the professional profession that he's in his university. He has some skills that is difficult to find in our community. He's humble. He have very practical advices. He judges the crucial decisions with very listening and hearing, you know. And thank you for inspiring all of us and keeping the vision of the 3 years of European Lung Foundation among difficult times like COVID it was. So I would like to thank you also. And Kjeld, together with Pippa and the whole team, I think that they have very warm environment, and you can feel it, and you can feel it in the flow of this event today that we have you all. So in this moment, if I want to introduce myself to know us better, I would tell you that I have nothing to do with health. At least this I was thinking before some years. My studies was graphic design. Then I was in fine arts in Spain. My Spanish are much better than my English. And then I continued to study architecture. So my passion is design. Why I mention this? Because despite the fact that I'm a cystic fibrosis patient, I try in all my life to be a normal person, to have dreams. Before 12 years, I realized that a lot of times the circumstances and the environment that you grow make a lot of limitations. So in Greece, if you have heard in 2010, the economical crisis, they shut down some units, hospital units, including my CF unit, and then I feel that I was treated, a threat, a danger. And then I realized that in Greece we have 10 years less life expectancy, not because of the cystic fibrosis of our disease, because of the healthcare system. And losing one patient per month, I understand that we have to take the active option, like it's in here. And I take the action option, and I dedicate my life in patient advocacy. I have been a part all of these years in different national and international associations and committees. The Hilde that you already saw in the previous panel, I know her more than 12 years. And I understand that we can change our lives and the healthcare system when we take the life option. And this became more obvious 2 years before, when the treatment, the innovation therapy that saved the CF patient, discovered and approved in America. But the problem, a lot of times, you know better than me, is the money, and the money of the innovation therapies. And this innovation therapy, it was cost about 300,000 per patient per year. So this was a limitation that we face everybody. And I take the active option to deny my lung transplant in order to press to have this treatment in Greece and to save ourselves. And we did it. We did it with international collaboration, with patient empowerment, and with the knowledge that we want. And this was the reason that I make a master in leadership, patient leadership, in order to know how to fight for to make better our lives. And this occasion was that I met closely the ELF, and now with this experience, I want to share my next 3 years together with you to see how we can limit the limitations and to have better lives. So if I make a helicopter view, what we will face the next 3 years, I think you will agree with me that the digital transformation in health changed a lot. The hospital is not on the hospital. Maybe it becomes in our home, in our office. We have digital devices. We have a smarter system that we can take advantage to have a better healthcare. The AI, the real-world data, can help us to make prolapses, to make better decisions. And all this knowledge, we want to be part of this. The main challenge on this is that we are different patients with different skills, with different needs, with different diseases, and not every solution is based on our personality. So for this reason, we want for each solution the patient to be at the center of the services. If I want to put together the 3 priorities that I can see, is that first of all, we want to be co-design health care solution for lung diseases, and to be patient-driven the policies. The second is to be everybody empowered. We want empowered communities, and don't mean only the patient. We want to educate, to empower the doctors, the physicians, the politicians, to take all together the better choices. And the third one, without the networking and collaborating together, we cannot do nothing. So we want multi-knowledge ecosystem networks to take the best practices and to implement it. In the news, we can see a lot of times disasters now, fires, and a lot of environment dangerous things. So we understand that the air that we breathe, it's not independent of our health. For this reason, in the heart of ELF, we have the environment policies. Finally, after saying all of this, I would like to invite you, all of you, and the others that were listening in the 3-year journey to make better life with Breath Unlimited, because you know better than me that in this life journey, every breath counts. Hope to be all together to co-design our future in the respiratory field. Thank you, everybody.
Thank you very much, Dimitris, for these encouraging words. Now I would like to round off the day, and I also want to extend a few thank yous. Of course, thank you to Michaela and Liam and to Hilde for helping to lead this session. Thank you to all the speakers. Not least, thank you to the technical staff who have directed us with great expertise, like we are in the movies, and I hope everyone has benefited from all your great skills. I want to also highlight a few people who, like the people attending online, you never see on stage. It's the ELF team. So if the ELF team with Courtney, who arranged all this, come to the stage to have an applause, I'll be very grateful. These are the people who, time after time, again, save us and organize the events that we all are very fond of and we all find so beneficial and so helpful in our life. And not only us, but also on the clinician side. So thank you very much to the wonderful ELF team, and thank you also to Pippa, who you can look at the side of the room, too shy to come to the center. Thank you. I want to mention that, of course, we do have the poster and video session on the ELF website. So many of you have sent in your posters, so do check them out on the ELF website. We also have a guide to all the patients' involvement sessions at the Congress. So if you stick around, do check it out and go listen to and support your fellow patients. It is indeed great to have you back in Congress. I do look forward to every chance that we have in the coming days to meet, perhaps at the ELF stand in the World Village, to have a chat and discuss, exchange experiences, and hearing about what's on your mind. We will have we will have the daily social events, and we will also have our coffee and clean air talks, where we also invite clinicians and patients to come and receive our advocacy pack to become advocates for a better climate. For those of you who continue to stay here today, we do have the opening session, the welcome reception, at 17:45. Until then, we do maintain this room, so feel free to hang around and have a drink and have a chat. For everyone who joined today, online and in person, thank you, and see you again next year.